Good evening. I am Dr. Kane from Hinduja Hospital, Mumbai, and with me are two illustrious people here. Dr. Dhiren Shah is from SIMS Hospital, Ahmedabad. He is a cardiac surgeon, a prolific cardiac surgeon there, and we have a transplant cardiologist from Mumbai, Fortis Hospital, Mulund, Dr. Meeran. We will be discussing some aspects of cardiac transplant with these two important doctors who are practicing their day in, day out, and they have a large experience. I am basically an interventional cardiologist, so I am the person who probably refers them these patients. So I would start with the first question is, when you have a patient, all of us agree that heart failure is the commonest reason why we do transplant, though there are multiple other reasons probably. But how do you select a patient of heart failure? When do you think he needs a transplant? How do you go about the decision making?
So I think it is very critical to identify the right patient for cardiac transplantation. You need to identify patients with advanced heart failure. When I start looking at patients with cardiomyopathy, certain signs that I look at to identify patients are, if they have recurrent hospitalizations due to heart failure. Because each hospitalization, if you look at statistically, increases their risk for subsequent hospitalization for heart failure. So frequent flyers to the hospital, inability to tolerate evidence-based guideline-directed medical therapy because of renal dysfunction, because of hypotension, because of various other reasons. Third, worsening LV metrics on echocardiograph despite maximally tolerated medical therapy. Those three are the biggest sort of indicators for me, and the fourth one too, increasing use of loop diuretics. So you're going up on the doses without any symptomatic relief. So those are the sort of common things which one can easily pick up in their clinics, and then sort of route them to the advanced heart failure centers. And I think those would be the right people to channel our efforts on. And in those cases, I think you will get better benefit. So there's a risk benefit arm in everything we do in medicine, and I think if you select the right patients, the benefits would outweigh the sort of risks of heart transplant in these people.
Dhiren, would you like to add to this?
Yeah, I think so. He's correctly listed out the type of the patient. I just would like to add one more important point is, before enlisting a patient for a heart transplant, it is always mandatory that the patient is on optimal medical therapy for at least 3 months period. Only after 3 months period, if still the patient is not doing well, then definitely he can be thought of for listing on a heart transplant list. And second very important thing is, patient should not be too sick. Patient should be sick for a heart transplant, but he should not be too sick to be enlisted on a heart transplant.
No, this is very important for me, as a person who is going to refer you these patients. When do we say somebody is too sick? Means when would you not like to have it's being a delayed transfer to you? So it's most important for everybody to know when to refer rather than a delayed reference when everything else has been late.
I think my simplest response would be if you are the reason you're too sick is if your other end organs start failing. So we know that in the whole sequence, the clinical spectrum of heart failure, as other end organs start failing, you are bound to have very high pressures in the heart as well as in the lungs, and up to a certain extent the pressures in the lungs will revert if you do a cardiac transplant, but up to a certain point that may not reverse after. So I think, again, to be very simplistic, preserved end organ function would be ideal. If you have cardiorenal syndrome and the kidney numbers keep going up and down with diuretics, that's still sort of, I would look at that with optimism. But if the renal dysfunction just keeps going on worsening, then that's a bad sign. Then you are actually looking at a situation where you're going to think of double organ transplants.
Okay, now suppose we refer you a patient, whatever stage it is, depending on that. What are the things that you do when you get this patient? Like how do you sort of prepare him or investigate him for making him a candidate for the transplant?
So in the Indian setting, at the very first meeting, I tend to not overburden them with too much information, because imagine if you're sitting across the desk as the patient, I'm telling you that, you have advanced heart failure, your 1-year mortality is high, and if I do a transplant, all of these things will happen. So give them sort of information in small boluses, but what we do is, first of all, we need to gauge in the first sort of meeting is the patient psychologically prepared or not. I think that's the biggest hurdle, because a lot of patients have denial of their own diagnosis. They may understand that they have cardiomyopathy but not sick enough to require this. So that's the first hurdle. Once you sort of cross that, then there are several sort of investigations that are to be done. I don't want to go over the entire list, but the basic is to ensure that the other end organs are okay. We are going to rule out significant kidney dysfunction, significant liver dysfunction. Very essential to also rule out any significant peripheral arterial disease, or which could actually limit their ability to participate in cardiac rehab even after a successful cardiac transplant. And a few more things like doing a right heart catheterization to measure their the pulmonary artery pressure and calculate the pulmonary vascular resistance and the transpulmonary gradient, because that again is a very important distinguishing feature, because if the transpulmonary gradient and the pulmonary vascular resistance are high, both of them could cause heart failure even in the new heart. So right heart catheterization, peripheral rule out peripheral arterial disease, make sure kidney livers are okay. We also do a test to see how immunogenic their immune system is, to predict their future chance of rejection. So we do an antibody screen, and there are various methods. You could do a PRA, panel of reactive antibodies, or you could simply do a HLA antibody screening, and various institutions have their own methods of doing that.
Okay, just an extension of that I would like to ask you is, we always say in medicine, you must know, before you do something, you must know what not to do. So how do you decide, I'm not going to do this transplant, this patient is not a candidate for transplant? I suppose that's also is important for all of us.
Actually speaking, there are very specific absolute contraindications for heart transplant.
So what are they?
So again, what he told is end organ damaged. So for example, if the patient is having creatinine of persistent creatinine of more than 2, or the GFR is less than 50 persistently, which is not improving by even the diuresis and decongestion, then definitely that patient is a very high risk candidate. Okay. Patient is having liver dysfunction, patient is having high PVR, that is pulmonary vascular resistance more than 5, which after the medication is not reverting back, coming down, then these are absolute contraindication. Patient having shorter lifespan because of some infection or malignancies there in the patient. Patient with diabetes mellitus but with end organ damage. So if the patient is diabetes but end organs are fine, the eyes and the kidneys and everything are fine, then yes, he is a candidate for transplant, but with end organ damage, he is not a candidate. If the patient is having COPD, and peripheral vascular disease, so these are the set of the patient, I would say they are not a good candidate for a heart transplant, because post-operatively they don't do well.
So maybe we'll inform them that you are higher risk for whatever success. Now having taken a patient, and now we'll consider two scenarios. One is stable, so everything is perfectly suitable and he requires a transplant according to you, and now he has to wait for a donor. So what does he do in the interim period, and how does a donor come?
So each state, in India, with each state there is a different zonal transplant committee. In Mumbai we have a ZTCC Mumbai, in Maharashtra we have ZTCC Mumbai, we have ZTCC Pune. So there's two different organizations. But anyways, once you register a patient, they get a number on the state list. So depending on that number, depending on their body size, depending on their blood group, the waiting period could vary. Based on our center's experience, the average waiting group for an average size person who is not an O blood group is roughly around 1 to 2 months. I have had patients who have been lucky to receive organs within 2 days too. So it could be, and I have had patients who are unlucky to be on the waiting list for 6 months too. So it could be extreme, but average is around 2 months. In the interim, you want them to be on appropriate medical therapy, and always keep in sort of frequent touch with them. Don't forget, don't just list them and say bye bye, and the next call you give them is 6 months later for a transplant. So you have to keep in frequent touch with them, either if they are from out of state, out of the city, phone calls just to make sure all the blood tests are okay, the end organs are still fine, and they are not sort of spiraling down. There are certain patients who actually, while on the wait list, decompensate, and then we have to act more quickly. So what we've done is we've put them on mechanical circulatory support, like maybe a temporary LVAD or even an ECMO, preferably an LVAD because it could be kept longer. What that does is it boosts them up. If you have a mechanical circulatory support, it boosts them up on the transplant wait list, and they gain priority listing in the region and also on the national transplant list.
How is it in your state?
In our state actually we don't have the SOTO committee. It's already in the process of getting it enlisted.
Hopefully.
But we have the government authority who decides to share the organs. In Gujarat, we are the only center who are doing heart transplant, so there is no such issue. Another important thing which I would just add on to this is there are patients who are really very sick, and we have kept a few patients on home milrinone therapy also. It is home milrinone therapy.
Home milrinone.
Yeah.
So that is intravenous. So with
intravenous.
the indwelling catheter.
Yeah, indwelling. We put a cava fix or central line, and that patients are on home milrinone therapy, and that really optimizes the patients in between period of time while they are waiting for an organ. Second very important thing is once the patient is listed for organ transplantation, we ask each and every patient to be in the periphery of 100 kilometers of the transplant center, because whenever there is a call, you don't have much time between. So I cannot call a patient, probably if the patient is in Ahmedabad and the patient center is in Ahmedabad and patient is in Jamnagar. He cannot reach there. It takes 6 hours time to just reach there. So he has to be in the periphery of 100 kilometers so that he can reach there. So these are the few things we really tell them, and if they are very sick, every week we call them, optimize them, see the parameters, blood parameters, weight, and this parameters we try to check.
How is it the scenario, like suppose you have a brain dead patient, how easy it is to what do you need to do to get that heart in a brain dead patient?
So there's a long sequence of events. First of all, if the patient is confirmed to be brain dead, so means you need to have 2 apnea tests which confirms by appropriately.
So let's go beyond that now.
Yeah, so appropriately. So that's done. So what happens is that donor hospital needs to inform their social worker. Their social worker will then inform the ZTCC Mumbai. ZTCC Mumbai will then send out an alert according to patients. They have the ZTCC Mumbai will have a list of all the prospective recipients based on their blood group, weight, age, everything, and then based on where the rank is, they will give you a call saying that this is the offer, so and so patient, so many years age, these are the basic findings, ECG, echocardiograms, blood groups, and blood test. So then the recipient team, so our team will then kick into action. We'll look at all the parameters, and if we feel that this is a good fit based on the weight, age, and the other parameters that we look at on echocardiogram, ECG, then we'll say yes, okay, we accept it. If we don't, then we turn.
So all these decisions are done within minutes, hours, or what?
Yeah. So we don't have many hours. I would say within minutes to maybe an hour or two. We can't sit on it for too long, because you have to remember, we have to preserve the donor as well.
So how much time is allowed? Is okay, or is?
So we say there is a time limit of 4 hours, but that 4 hours is the time limit between us going and extracting that organ and us implanting it in the new recipient. Before that, there is no time limit as such, but we need to be quick, because we have to remember, once the brain death happens, there is sort of a cycle of catastrophic neurohormonal changes that take place, and there's always a fight to try to preserve all the organs for other.
So what I would like to know, is where is the time maximum wasted? Means what are the issues that you all face, or means Is it from the patient relatives or from the local hospital or the transplant center? So where is the delay occur generally, and how can that be avoided?
So
what would you tell the public or the doctors or the physicians who look after these patients finally?
So we get notified only once the family has given consent. So there is not much delay, at least in, when I come to know about it, there is not much delay from the family's side.
I think so. It is the delay between when you counsel the relatives that the patient is brain dead and the patient can be a potential organ donor. So from counseling and to consent, that is the time delay which is wasted. And in that time delay, the neurohormonal changes that occurs, so that really reduces the potency and of the organs.
But suppose the person had already given consent that he wants to be a donor, then is it faster if that such a consent is, or you still need the...
Again, the relatives can override that consent. So, and that's not only in India, even in USA, even if you're a registered donor and if the relatives say no, then you can't really go ahead.
We have an opt-in consent in India. There are countries where there is an opt-out consent.
What is this?
Opt-out is in French and Spain or Croatia. Every citizen of that country is potential organ donor. If you don't want to donate an organ, then you have to file an affidavit or you have to tell the government, I don't want to donate.
Okay.
Wherein in India, it is opt-in. Means if I want to be an organ donor, I have to register. And still again, at that point of time, it is the relatives, my near and dear ones, they are supposed to give the consent. And along with that, I would just add one more point. When the organ donor is there, donor optimization is a very paramount important to get the good quality of organs.
So what do you mean by this donor optimization?
So, because once the brain death occurs, then there is severe neurohormonal changes in the body. And to maintain that neurohormonal changes, you need to supplement that patients with steroids, with thyroxines, and then you need to give vasopressin because that patients have diabetes insipidus, and so sodium levels goes up. You need
you're talking about a brain dead patient?
Brain dead patient. Brain dead patient. Okay. You need to be, on the contrary, more vigilant and more critical in managing that patient.
Who does that? Because
it's
you are not in the picture at that time.
Exactly.
So that's done by the local
critical care specialist. So each and every ICU specialist should be knowing,
be aware of all this.
Okay, what is donor optimization. And there is an app on Android also, which has been made by Mohan Foundation. You can go through that. It's a donor optimization. There are just few steps which you need to take care of. So that
it's very important information.
Very important. So that you can give better organs to the patient.
Oh, that's interesting.
You mentioned the delay in time. Very often we are allocated an organ and we go there and find that the donor is on industrial doses of pressors, and sodium is 160.
Not hydrated.
Yeah, not hydrated. So you have to sort of go and we fine tune things.
Now that we get the organ, you have done the transplant. Now what? How do you manage that post-operatively? How does the patient's family? What is the expense involved now in this whole process, and how do you help the patient out?
So the expenses are again differs from institute to institute all across India. Post transplant, the surveillance part requires biopsies. Again, the biopsy schedule also depends on institution to institution. But the most important thing is them taking immunosuppressant medications and being able to afford it. At our center, what we tell patients before I do a transplant is, come what may, you should set aside at least 14 to 15,000 rupees every month for immunosuppression, plus all the tests related to immunosuppression and echocardiogram. So all of those things will be included in that, at least for the first 1 year. After the 1 year, your frequency of surveillance, frequency of testing is reduced. So that cost will slowly come down, but upfront you should be able to afford that much for immunosuppression and relevant testing.
Okay, having done this, and I think there must be several ways of helping out these patients financially if they are not affording. I would know what is the long-term survival, just to know that how encouraging it is for a person to go through it. What is your experience, and In the literature we know that long-term survival is good, but what is the experience in India? What is the longest term survival that you all have had, and how does it go?
So in India, unfortunately, we don't have good data representing our results. From my personal experience at my center, from a single center, we've done in the last 3.5 to 4 years, we've done about 105 total heart transplants. The 2-year survival is roughly around 80 to 82%, which is comparable to what is quoted in international literature.
Absolutely.
And if you look at a subset of that, the pediatric patients less than 18 years, our 1-year survival is in excess of 90%. Our 2-year survival is roughly around 85 to 90%, which is excellent. So out of the 22 pediatric transplants that we've done, we have had only 3 mortalities. So which is
okay. A word about pediatric. When do children need cardiac transplant? Are the indications same as adults, or what is it like? How different it is?
I think so. The indications in congenitals are, one is the congenital anomalies which are not repairable, and second is, again, there are few sets of patients who have dilated cardiomyopathies also. So this, and plus there are patients who have converted into Mangas.
Yeah, okay.
They are actually the candidates for heart and lung transplant, not only heart transplant but heart and lung transplants.
Absolutely.
And if you look at the long-term survival, I would say the median survival, that is at the end of 12 years, 50 to 60% patients are surviving world over. In India also, at Ahmedabad, I have 2 patients who are in follow-up who had transplant 14 years back, and they are doing fine. So
it's very interesting to know that long-term survival is good, and we are doing as well as anywhere abroad, and we have all the facilities. Financial constraints, I say the whole world faces that, and maybe we face it a little more. As a parting shot, I would like you to give some message to physicians and general public as such about heart transplant. What would you like to tell the...
If there is one single message I would like to tell the general community and the general physicians is promote organ donation. That is the biggest lacune in transplant the world over, not in India. What I always say is that if you can convince one person in your entire lifetime to donate their organs, and if that one person can do that to another one person, I think one of the biggest problems in transplant community would be solved. That would be my number one message to the community.
Good. Dhiren, what would you?
See, my message would be, unfortunately in India, still in the physician community and even in the cardiologist community, there is still a myth that heart transplant in India cannot occur, and the results are not good. But let me tell you, overall results, if you look at the overall data all over India, the results are fantastic. So any patient of heart failure should be given an option of heart transplant now. It should be mandatory. Second very important thing which I have observed in over a period of last 3-4 years is, we always say that we are lacking organ donors, but there are many centers wherein organs are there but the recipients are not there.
Okay.
Recipients
okay,
are
so you have
not
the
there.
reverse problem.
Thing.
Okay.
So basically, again, I don't think so there are no heart failure patients in any whole country. There are a huge number of heart failure patients.
Absolutely. We
but
have
unfortunately,
very large
they are
numbers,
not being referred
to
for the heart transplantation. They are not given an option for heart transplantation. So sometimes I feel bad that organ is getting wasted. Sometimes it does occur in Gujarat also, organs get wasted.
Friends, we have had a good discussion, and I think we need to still increase the level of awareness, not only in the general public, also among physicians, also among cardiologists who look after these patients. And maybe what I realized from discussing with you, that maybe an early referral, so that the transplant team is in the loop that such a patient may need a transplant, and getting the people to be aware to come forward for donation, getting their consent in good time, so that the valuable time is not wasted post brain death is certified, would go a long way in helping us out to do a better transplant, a larger number of transplants, and it will help the population at large. Thank you very much. Thank you very much for your
Thank you.
Yeah.